All right, good afternoon, everyone. I'm really excited about this next presentation. Hello, everyone, thank you. Like I said, I'm really excited about our next speaker because obviously the challenges facing rural healthcare are very dire, right? And there's no way to really minimize the serious challenges. But there might be a ray of hope, perhaps. We'll see. I'm really excited to introduce to you Dr. Bruce Struminger, who's Associate Director of Project ECHO. And I can say I'm currently doing a policy fellowship in DC through the Agency of Healthcare Research and Quality, and they talk about Project ECHO all the time because they're one of the early supporters and funders of it, and it's been a major success. One way to measure the success is if you look at the last Congress, right, one of the most partisan, do-nothing Congresses, they passed the Project ECHO Act with unanimous support in both the Senate and House, right? It's 97-0 in the Senate, unanimous in the House. It was sponsored in the Senate by Senators Orrin Hatch and Brian Schatz from Hawaii. We have someone who's working on Brian Schatz's staff in the next panel. But back to Bruce, he's a graduate of Harvard College with degrees in art history. That's really interesting. And medical anthropology, then completed his MD at Johns Hopkins University. And following that, he was an internal medicine doctor and public health practitioner for 6 years with the U.S. Indian Health Service on the Navajo Indian Reservation. That was in Shiprock. Yeah. And then for 6 years, he worked with the CDC as a country director in Cote d'Ivoire and Vietnam. And following the stint with the CDC, he transitioned to the University of Mexico, which is the home institution for Project ECHO. And I'll let him describe that more in depth. But it's just been, like I said, something that's really excited a lot of policymakers around the country, especially in DC, and Dr. Struminger will tell us why.
Fazil, thank you, and thanks to Mason and Bill. Where is Bill? There he is. Okay, for organizing this really terrific symposium. Glad to see that you're building on what you started last year, and I hope this does become an annual event. And maybe as we were talking during the break, you might even create some ways to keep this going in between these annual events. It was really also thanks to all the participants and for people sticking around all day. You're really, being able to have some of the dialogue at the end of these has been super interesting. I was also saying to Fazil, bringing all these different diverse stakeholders together to talk about rural health, this is a really great idea that should be disseminated to other states, and I'll take it back to New Mexico and talk to some of my colleagues because I think there's a lot of value. If you weren't sure at the beginning of the day that there are a lot of challenges in rural health today, I am sure at this point of the day you're quite convinced that the challenges are diverse and complex, and we're going to need all the collaboration we possibly can get in brainstorming and working together to find solutions. What I'm going to be talking about Project ECHO, hopefully I'm hoping to plant a seed here, an idea that might offer some possible solutions to at least some of the workforce development and collaborative problem solving and access to complex care and specialty care issues that are faced in rural areas. So Project ECHO stands for extension. The ECHO part is extension for community healthcare outcomes. The extension part it's a metaphor drawing on the agricultural extension worker model. So the idea where, agricultural and extension school expert goes out and works with farmers, disseminating best practices, usually driving out there in their pickup truck. So this is the 21st century model where we're trying to move knowledge and not people and patients. So using video conferencing is one way to bring people together to collaborate and disseminate best practices and knowledge. In our case, doing this in the healthcare space. This project or initiative is now a global initiative. There are over 30 countries implementing ECHO programs. There are over 35 states in the United States implementing them. But it started in New Mexico to address a rural healthcare challenge, which remains, but was very much 15 years ago in 2003 when this started. Hepatitis C was a significant public health issue in New Mexico. It's a significant public health issue across the United States and globally. But 15 years ago, Sanjeev Arora, who's the director and who came up with this idea and founded the organization, he was the only clinician treating hepatitis C in New Mexico. And we have about 35,000 plus Hep C patients. So he was treating about 100 patients a year. 15 years ago, the treatment was interferon and ribavirin. You had to come in and get these interferon shots every month for 12 months. It was really toxic and complicated to manage. People had a lot of mental health. Suicidality was a big issue around interferon treatment. And so he was treating about 100 people a year. So at that rate, it would take 300 years to treat the epidemic. So he realized this is not going to work. We need to do something differently. Video conferencing was becoming available about that time. And he thought, what if I could go out and recruit a primary care clinician in almost every county in New Mexico to be part of a network that he would mentor. They would present their patient cases, and people would be able to get treated locally, get their Hep C treated locally under his guided practice. Over time, they would go from being novices to experts in the same way medical students and residents and fellows go from being novices to experts through the case-based learning they do when they take care of patients and present them to their attending physicians, that he could build a network and a kind of workforce to address Hep C in New Mexico. So that's where it started. At this point, as I said, there are programs actually in over 60 subject areas and with over 200 partner organizations in over 30 countries. I have no financial conflicts of interest to report. Just wanted to show you one photograph just to fill your imagination a little. This is a picture of the India National Institute of TB and Respiratory Disease multi-drug resistant TB echo, which launched back in November of last year. And in this case, there are this group of people, and there are about 120 to 140 people up there in 30 district TB offices in Delhi. In Delhi, they treat 60,000 TB patients a year. The United States treats 10,000 TB patients a year. They treat 5,000 MDR patients a year. In the US, there are 100 MDR patients a year. They have so many MDR patients. Actually, in this group that meets weekly, they only discuss XDR cases because MDR is sort of too simple. And they have about 200 XDR cases. So anyway, this group of clinicians, doctors, nurses, laboratorians working on TB come together every week to discuss a number of difficult cases. So our mission is to democratize medical knowledge and help get best practice care to underserved people all over the world. For many of those people, they're living in rural areas. Most of them actually are living in rural areas, but also underserved people in urban areas. And we have a goal of improving the lives of 1 billion people by 2025. That's sort of our guiding target. So the methodology, in some ways, this is the most important slide. This is a bundle of best practices, each of which has been used for a variety of things, but the putting them together into this combination of bridging geography by using video conferencing, which over the last 10 years has gotten cheaper almost to the point of, I use a video conferencing platform that costs $15 a month. You can use your smartphone or iPad or laptop or any device that can connect to the internet and has a camera and some speakers on it can allow people to join these networks. It doesn't require expensive equipment like it used to. Macarena and I worked together in Vietnam. We overlapped for a month back in 2009. Actually, that was when I read about Project Echo in an article in the New England Journal that came out in 2011. But when I arrived in Hanoi, one of the things that really amazed me was how our office was using video conferencing to connect Hanoi and Ho Chi Minh City, where we had a large team. And we were literally using this video conferencing system 3 to 4 hours a day to collaborate with our team in Ho Chi Minh City. And it was the routine way of doing business. And I always thought it was amazing when I got on these other CDC calls, which even remains today for the most part. I'm trying to actually help. And I think I've made some progress helping change the CDC culture about teleconferences and introduced video conferencing in a way that's actually taking off in parts of the CDC. But anyway, using this technology to bridge geography and leverage the scarce healthcare resources of the primary care clinicians out in the field, in local rural communities, with the scarce experts, whether they're in academic medical centers or other centers of excellence. It's really a case-based learning model. That, to me, is the most important part of this. It's not the technology. The technology are the railroad tracks that bring people together, but it's really, and one of the speakers earlier was saying, you know, why is storytelling, why is it that that's how we need to get people engaged? Well, stories do engage people, and case-based learning really is a form of storytelling. And I mean, there's been a lot of research done on adult learning, and I think we know quite well at this point that case-based learning does, for many adults, the learning, the maintenance and retention of information when you learn things through stories is often much deeper than simply passively sitting and listening for an hour to a lecture or getting online and reading something. Those can be very effective for conveying information, but in particular when you're trying to talk about complex topics that don't necessarily have a black and white answer, being able to have a dynamic learning situation and to hear stories just helps us learn better. Sharing best practices. So whether it's, and we often, in whether they're hour or 2-hour sessions, and whether they're weekly or biweekly or monthly, we always have a 15-minute, a very brief didactic presentation that's evidence-based and references literature so that, you know, we're all working with facts, hopefully not alternative facts, but real facts. And but that the most of the learning is through the cases that are presented and the discussion that goes on around those. Reinforcing clinical guidelines and normative practices. We also monitor and evaluate outcomes as a standard part of quality improvement of the work we're doing. So we give continuing medical and pharmacy credits and nursing credits for the programs we're doing, which are a form of continuing professional development. We then get feedback. In order for people to get those credits, they have to answer 5 or 7 questions. So we're always doing our own continuous quality improvement. If we have money to do it, then doing larger, ideally patient-level outcomes type research. We've been able to do a couple studies. But anyway, there's a whole variety of levels of evaluation, but it's a core principle for us. So these are the core principles. How these are applied in practice is varied tremendously, both in the programs we implement in New Mexico and the ones our partners implement in other places. This is just to show another picture. We have a collaboration with the Indian Health Service. This is another TB echo. This includes, it's the Navajo Reservation or Navajo Nation, the Indian Health Service, the state of Arizona, the state of New Mexico, the CDC, and all come together once a month to talk about TB cases. So it's a state, tribal, federal collaboration. We're able to look at patient information that's de-identified, and then this is an MRI on the right, or chest x-rays or whatever. We're able to share images as needed. Just to differentiate the teleecho model, which is really a telehealth model versus telemedicine. Telemedicine is generally defined as, you know, a patient being in one location, a provider in another, using video conferencing to bridge that geography. That is fabulous and amazing to be able to do that. One thing it doesn't do is extend your bandwidth in terms of the number of patients you're able to treat. It just means that one provider who might be able to see 20 patients in a day, using telemedicine might be able to see 5 of them or whatever the number is who are located in other places, but they're not going to see more than a certain number of patients and might actually see a few less. We're focused on the providers who, in teaching them and training them, whether it's to treat Hep C or HIV or rheumatologic diseases or heart failure or what have you, that they learn from a few cases that they're presenting, but then they're going to go and apply what they learned to 10 or 20 or 100 other patients they're taking care of with similar conditions. It's very much, the model is very dynamic. The idea is to really promote peer-to-peer learning also. Even though there are subject matter experts involved, we have heard time and again that people actually appreciate the peer-to-peer learning more than they really value even the expert input that they get. So we try to keep things very dynamic, and everyone who's coming, we consider them local experts or a variety of different experts. So everyone's essentially a teacher and everyone's a learner in this environment. Also, it offers a fabulous opportunity for bridge building across our fractured healthcare system to be able to link and collaborate between academic medical centers, departments of health, the private sector, FQHCs, et cetera. It's one very easy way on this, a video conference platform. People can come in from wherever they are, where they work, and it means you can put together all the people you feel need to be in the discussion. Also, very much emphasizing interprofessional collaboration. So making sure, often for us, we'll have a physician expert, a pharmacist, a psychiatrist if needed, a social worker, a community health worker, and we try not only to have those on the hub end of this hub and spoke model, but also to encourage the participants in the field to bring their multidisciplinary teams to participate as well. In 2011, an article was published in the New England Journal, which was essentially the proof of concept. This was publishing the results of a study, which was a prospective cohort study looking at patients in New Mexico being treated. So Dr. Aurora went around, as I said, all over New Mexico and recruited clinicians, some of them doctors, some of them nurse practitioners, pharmacists also in the Indian Health Service system, some in the correction system. So it was a combination of IHS, Federal Qualified Health Centers, and correction facilities to participate in this ECHO network. And over about a 1.5-year period or 2-year period, 400 patients were randomized either to get their treatment locally by their local clinician, who would then present their case over the video network to Dr. Aurora and the other experts and get recommendations on how to treat them, and patients who had to travel to Albuquerque to the University of New Mexico. And what they found is the treatment outcomes were equivalent. The patients treated locally had cure rates just as good as the patients who went to the academic medical center. And actually for minorities, they did better, which in some ways is not surprising. The people being treated locally were more comfortable and completed their treatment, and some of them just found going into the big city and going to a big academic medical center intimidating. So this issue was really about increasing access to care. As I said, back in 2004, he was treating 100 patients a year. Now, 1,500 patients a year almost are being treated, 80% of them out in the community by primary care clinicians under the guided practice of this model. Just to summarize some of the benefits to rural clinicians, they're learning knowledge that they might not, it's tough to keep up. I get the New England Journal every week. I have a tough time even keeping up with that, much less the 100 other journals that are coming out every week on different fields. So having, whether it's academic experts or Center of Excellence experts who are keeping up with narrow fields of study and sharing those updates that are significant, it allows for rapid dissemination of knowledge across a network. This peer-to-peer learning is really important. As Fazil said, I work for the Indian Health Service in a pretty remote part of the Navajo reservation. It wasn't easy. It wasn't easy to go to grand rounds and go to lots of things that are available in academic medical centers. Being able to participate and be a part of a learning community, even when you're out in the middle of a very remote area, is very attractive and makes you feel professionally less isolated. Getting the CPDs or CMEs is also helpful. terms of benefits to the health system, in many respects, this is a quality improvement initiative. It is about increasing access to care that might not be available because of a lack of specialists. It's a way of delivering workforce development, reducing travel for patients. Often, if people are having to come, we have one pediatric endocrinologist in the state of New Mexico. The wait is 6 to 9 months to get an appointment with him. So, for that person to be able to help local primary care clinicians to see patients much more quickly and consult really helps the health system. It also has been a great way to integrate public health and clinical medicine. But we realized, Hep C was where this started, but there was no reason this model couldn't work for lots of other issues. And actually, the first other issue, because Hep C is often transmitted through injecting drug use. In New Mexico, we've had a long history of a heroin epidemic in northern New Mexico. That transitioned to an opioid epidemic about 10 years ago. There's still a heroin epidemic, and as we heard, heroin now is so cheap, we're probably going to end up having things go back more to heroin as opiates become less available. But we can treat someone's Hep C, but if we don't treat their addiction, and many people got addicted because of chronic pain, if we're not treating those things, they're just going to get Hep C again because they're going to keep injecting. And if you don't help go to the root causes, treating their condition once isn't going to be very helpful. So we started programs related to chronic addiction and chronic pain and addiction and substance abuse 10 years ago, actually. This is a list. We run over 25 programs, 20 of which serve New Mexico for a whole list of different medical issues. We have 5 collaborations that are national with the Indian Health Service. We have 1 collaboration with the CDC that's actually a population health program where the CDC is funding 23 tribal organizations across the US, creating population health programs, serving their local tribal communities. They come together every month over these video networks to talk about the public health programs they're developing and implementing and trying to accelerate sharing of best practices across that group. We collaborate with the Institute for Healthcare Improvement, doing one pilot with them over the last year and a half, trying to work with 20 federally qualified health centers to improve how they implement U.S. Preventative Services Task Force recommendations. So that's a process echo. And then we have a lot of community health worker programs, as well as a prison peer education program. We're next week launching a U.S.-Mexico border TB echo, which is going to be our first bilingual echo, which is going to have some interesting challenges. And we're launching an antibiotic stewardship echo, which actually is an issue very relevant for has been an issue relevant for our critical access hospitals in New Mexico, how to set up antibiotic stewardship programs in their hospitals. So that's what that program is going to help mentor them, about 15 critical access hospitals, as they're setting up their antibiotic stewardship programs. This is just showing our partners across the US, most of which are academic medical centers. Globally, this shows 22 countries that have implemented already programs. I'm going to Cote d'Ivoire in a week, and there are actually another 6 countries in Africa that are actively developing ECHO programs right now. This is just showing, you're going to get a super quick global health view, since that's one of the areas that I focus on quite a bit. But just to show that all of these countries, and several of them like Kenya actually have 3 programs right now and have 2 or 3 in the pipeline, that this idea is one that is being successfully implemented globally. Our first ECHO in Africa was in Namibia. This is just showing all the partners. It was supported by the CDC through PEPFAR. And we were asked to help the ministry to connect initially 10 hospitals that take care of about 60,000 HIV patients all over the country. They have a population of 2 million people in a country twice the size of New Mexico. So very rural, very, very spread out for many of the people. And this has been a super successful program that's now been going for a year and a half. They're expanding to 40 hospitals this year and to several other disease conditions. Kazakhstan and Kenya launched programs 6 months ago. We're using a variety of technologies. In Africa, actually, the cell phone networks are pretty extraordinary and getting better every month. So they're using 3 and 4G routers where they're connecting to the cell phone network and doing the video conferencing that way. In a couple cases in Kenya, they had to put in satellite, which works also. In Tanzania, they launched a laboratory echo a couple months ago, and another in Uganda just a month ago. This is Vietnam, where they launched the first TB echo about two years ago, actually. New Mexico, we also have a TB echo. Our issue in Vietnam, they treat 100,000 TB patients a year. In New Mexico, we treat 50. So we're a low burden state. Our problem is keeping the public health nurses so that their knowledge is current on TB, so that when they may only treat a TB patient every 2 years, and if they aren't sort of being kept up to date and up to speed, when they get their TB patient every 2 years, they're not going to be ready to know how to deal with that. So part of what we're doing is just trying to keep that knowledge alive in that pool of public health nurses in particular that do the case management. University of Washington has a similar program serving 5 states in the Northwest, and this was the Navajo Nation. Kenya, back to India. As I said, we're launching this US-Mexico program in a week. We also bring many of the program directors together every quarter to share best practices and how they're doing their, implementing their programs. This is where those CDC population health programs serving Native Americans are. In this case, this is kind of amazing that the person with the green bar around them is Ursula Bauer. She's the CDC director for the Center for Chronic Health. And she's getting to talk to all these grantees across the United States, and they're getting to talk to her in a way that is not standard. So she has been able to learn from them every month about what the challenges they're facing implementing the program CDC is funding them to do. We're also funded by HRSA to train primary care clinicians in 100 federally qualified health centers on opioid addiction treatment. This program launched about 2 months ago, and it's a collaboration with 5 other medical centers: Boston, University of Washington, the Billings Clinic, FQHC network in Montana. ASM is also a partner. But this is very relevant to the topic of opioid addiction that we heard about earlier today. So this is one way we're trying to help train physicians in primary care to be up to speed and comfortable treating opiate addiction. This shows the networks of these opiate addiction networks, training networks. Also, Children's Healthcare of Atlanta, when I was trying to think what are the programs in Georgia, they are implementing or preparing to implement 4 different programs in Georgia. Commercial sexual exploitation of children, ECHO, child abuse pediatrics fellowship, ECHO, a child advocacy centers, child abuse and neglect, ECHO, and a cancer survivorship, ECHO. This is just, I'm down to the last slide or two, I think. We also develop software to support all these networks, both to keep track of who's participating, where are they, how often are they participating, how often and what kind of cases are they presenting, as well as software that sends out messages, but basically a whole network of software to support these learning networks. This is just a picture. This is hopefully going to be launched in the next 3 to 6 months. And this is my last slide, just a reminder that we're trying to move knowledge instead of patients and providers. So thank you very, very much. Do we have time for? Sounds like we may have time for 1 or 2 questions, if anyone's got one. I think people are tired at this point of the day. Great. Well, anyway, I think these slides are going to be shared. My email's on there. If anyone wants to follow up with any questions, I'm happy to get back to you. So thanks very much.